Direct primary care is an innovative alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care is reclaiming my profession, my time with my patients, and redefining what real quality care means. I'm Dr. Frank Calisch, and this is my DPC story.
Dr. Frank Calisch is an internist who owns Waypoint DPC in Gulf Breeze, Florida. He attended the University of South Alabama College of Medicine and completed an internal medicine residency at Naval Medical Center in San Diego, California. He taught high school science before attending medical school and served in the Navy for 11 years. He has an interest in philosophy and medical ethics and served as the chair of the Healthcare Ethics Committee at Naval Hospital Guam during the pandemic. During his naval career, he saw how a large medical system has to use metrics to gauge success and how those metrics became meaningless as soon as they become the benchmarks. He found the DPC community online when he was about 2 years from completing his naval service and began planning what would eventually become Waypoint DPC. He had a couple of quote-unquote false starts, relocating twice for family reasons. He is now settling into his new location in Florida, which is a nice homecoming. He enjoys the deep personal connections he makes with his patients and is a zealous advocate for the direct care model. Thank you so much for tuning in. Find out more about DPC, including resources, discounts, my favorite tech tools, and more at mydpcstory.com. The mapper, again, has been updated, so you can look for practices by specialty. Follow us on your social media platforms at our handle at mydpcstory, and be sure to subscribe to our newsletter and, of course, the podcast feed, so you won't miss when the next episode drops. With that, I would like to welcome our guest. Welcome to the podcast, Dr. Calisch.
Hi, thank you so much for having me. I'm glad to be here.
I am also so glad to be here because it is wonderful to hear from a voice who has come from, like was said in your bio, such a metrics-based system that whether you're in residency, medical school, if you've been in residency for a few years, or if you've been in attending for 20 years, everyone can relate to the frustrations of a metrics-based system when it comes to the metrics that are actually meaningless when it comes to quality patient care. So let's talk about that, because for 11 years, you were a naval physician. And for those of us who might not be aware, what did the job as a naval physician entail?
A naval physician, it's really an interesting opportunity because you're, on one hand, you're a primary care physician for veterans, retirees, but also active duty patients. And whenever an active duty patient comes in, there's always this two sides of a coin of like, you want to be a treating physician, but you're also an advocate for the taxpayer, making sure that the sailor who's potentially going downrange is healthy enough for the fight, but also is taking care of the patient themselves too. So you're not just a patient advocate, but you're also the advocate for the Navy as well. And it's a hard role to learn because you are not always, you want to think about the patient's best interest first, but it's not the only consideration that you have.
And let me ask you there, because prior to becoming a naval physician, you went to medical school. Were you aware of the balance that you had to eventually maintain as a naval physician, the taxpayers' investment in the Navy itself, plus the patients who were right in front of you? Did you have any sense that that was going to be what was required of you when you were in medical school thinking about becoming a naval physician?
I think that what I knew about the Navy was similar to what I knew about medicine before going to medical school, which was not nearly enough. I had family in the Navy. My grandfather was a naval physician and he served in Korea. I have a cousin who went to the Naval Academy, and my sister was in the Navy as well. So when the recruiters came during our first semester, looking to say, hey, we can pay for medical school, the Navy was a natural choice for me just because of the family history. And they talked about the adventure and being a doctor on a ship and seeing the world and all of that. And that seemed very, very attractive to me. And those recruiters, they're not doctors. And so they don't know what being a naval physician is really like. So I kind of jumped in, a little bit sight unseen. And you pick up on these dynamics as you go. And it wasn't probably till I was 3/4 of my way through my naval career that I really understood what that balance really meant as far as advocating for the patient, but also caring for the interests of the Navy. And that was really apparent during the different roles that I had in the Navy, because in internal medicine, we have many different jobs, both the primary care, being hospitalists, being intensivists at times. In Guam, a lot of times we were the subspecialists as well. And in Guam, I also ran the MEPS clinic there. So all applicants looking to join the military from the Micronesia, the Marshall Islands, the Northern Marianas, all of them came through our clinic, and we had to evaluate them. And at that point, they're not really our patients as far as being treated, but we're evaluating them to see if they're fit for military service. So it was an interesting opportunity. Yeah.
So, with the expectation that you were really serving in a mixed bag of responsibilities because of not only taking care of people who were already in the Navy, but people who were applying to be in the Navy. When we talk about metrics in the world of stuff that really doesn't impact the quality of the patient care at the end of the day, what were you seeing that was driving your day-to-day work?
Right. So, right as I was finishing residency, the Veterans Affairs, there was a big VA scandal with the shadow lists of people waiting, a year to be seen. And so the drum that everyone beat was access, access, access. You're looking at how many appointments do you have open each day? When is your third next available? And as soon as everyone realizes that that's what big Navy's looking at, they start manipulating the numbers to make sure everything looks green. And everyone's afraid of being the standout. Like, well, your access doesn't line up. And so since they're manipulating the system so that everyone looks good to go, you miss out on actual leadership seeing the fact that you don't have enough resources to take care of the people that have been assigned to you. And I think we've known since the 1960s that whenever you put a metric as the cornerstone for how you drive a system, that metric becomes meaningless because everyone will work hard to game the system to make sure that metric looks as good as possible. I think we figured that out when we started tracking their outcomes. What do you see? You saw surgeons picking fewer and fewer unhealthy patients. And that's what really drove those numbers. Everyone wants their numbers to look better, right?
It's just so sad. And we know that, that can take the form and shape that it does in the fee-for-service system in so many ways. It's like, forget the Medicare wellness physical done by the physician. Like, the staff can call them and do that over the phone. Who cares what their degree is? Because the questions are all the same. It's like, we saw that locally. And it was just like, what have I been spending 45 minutes a patient for when I didn't know that people were cashing in on, we could do this faster with less quality care just because it's access at the end of the day. And,
Right.
it makes me crazy, and I'm sure it does other listeners also, to hear that, like, because of making things pretty, you didn't have the ability to have the resources to deliver the care that you needed to, especially given that you were there during the pandemic when we're fighting for, like, actually a handkerchief is not going to keep COVID away. Thank you so much. It would be great if we could have resources like masks to cover ourselves. And so I can't imagine, layering those two. So tell us about, as you kept on in your naval career, what did you see around you in terms of, like, were fellow naval physicians sticking with it, or did you see a high turnover in terms of people who were in medical service with you wherever you were serving?
Oh, yeah. It was definitely a bleeding in both directions, both getting out of the Navy and of, people who are qualified going towards subspecialties, because specialties didn't have nearly as much pressure on them as the primary care clinic. And so I saw it in family medicine with them going towards sports medicine fellowships, occupational health, and then in internal medicine, a lot of people, pushing towards the specialties because, it was a way out of the rat race. I would say burnout was more of a norm than an exception. And, finding out, learning more about the terminology of moral injury, that resonated so well with me when I started learning more about that. that, yeah, the option was always, do I provide good care to the person in front of me and now I'm an hour late for my next 15 appointments, or do I provide suboptimal care for the person in front of me? And oftentimes I was late, and as a father of, two kids, that was tough dynamic and hard calculus for us, so I could live with myself at the end of the day. It's tough because you're doing 50% as a physician, 50% as a husband, 50% as a father, and you're failing at all of them, and you're still spending 150% to, get through the day.
And this is why I am so grateful that you are sharing your story, because this is reality. Like, this is absolutely reality when people are doing work in an incentive-based system where people are cattle, and the more cattle you see per hour, the more money you make. Completely opposite of like, oh yes, the oath that we took when we went to medical school to do no harm. It's just like completely, I mean, we look at it different ways. We harm the patients by not taking good care of them. We harm their pocketbooks by just ordering a statin or whatever and not even thinking about, does your insurance cover it, and like, is that going to put you into bankruptcy because we ordered a thyroid lab that does not cost $204 and yet it does. It's pretty crazy. So let me
Yeah.
ask you here, because with experiencing what you did and balancing in your head, like, how am I supposed to keep all the balls in the air when I'm only firing at 50% and I would love to fire at 100% in all of these things? It was mentioned in your bio that you found DPC through the online community. So in that space of like, you're a naval physician and then you're looking for something else. Did you look for something else because you were planning a civilian role after you finished your time in the Navy? Is that how you started looking for another way and then you found DPC?
Right. There were several things pushing me out of the Navy. One, I was reaching a point in my career when I was going to be tasked with more administrative roles and less time in the clinic. And for some people, that's great, and that's what they want. They want to be just a leader or primarily a leader in the world. I wanted to spend more time in the clinic. The other side of that is that my children are entering middle school age, and I wanted a little bit more stability for them. And my wife is a civilian physician, and she uprooted her career several times for us. We could move around the world. And it was time to offer her a little bit more stability in her career too. And so it was the right time for us to say goodbye to the Navy. But, in my career as well, I mentioned before that other people kind of worked their way out of primary care. Some of those leadership roles that I took were in that last duty station. Some of that was trying to get out of the internal medicine clinic so that it just wasn't the day-to-day grind of 20 plus patients, plus all of the administrative overhead.
And in that space, when you were seeing other people around you leave primary care, go into subspecialty, leave the Navy, leave primary care in general, you chose to stay. And yes, like, you went into more of a civilian role. But in terms of, why did you not leave medicine, period, versus having hope in the model of direct primary care and choosing that going forward?
Yeah, I was pretty scared looking at what the options were like, leaving the military, going into the civilian world. I'd heard lots of stories of people leaving the military and then bouncing right back in, because as bad as it is in the military side, it's 10 times worse when you're in a giant industrial health system. And when I found the DPC community online, several Facebook groups, and then started reading Douglas Farago's book was my introduction. It was like a light came on, and I said, okay, well, this is actually viable as a solution, not just to finances, but just as a way to get through the day and maybe even practice medicine in a way that the way I thought I would when I was choosing to be a doctor, however many years ago.
And one thing I think about when you say that, especially, is, did you envision continuity as a root component of the joy in being a doctor when you became a doctor after medical school?
Yes, I was a history and philosophy major for the first 2 years of undergrad, and I wanted to teach primarily. And because of my family history with medicine, I'd kind of shied away from it, and I just didn't want to do it as kind of like a quote unquote easy path. And my mom got sick, and when I was in undergrad, and she delayed her medical care for a number of reasons. And primarily it was because she didn't have a good connection with the people offering her medical care. And she wound up passing away when I was an undergrad. And I wanted to pursue medicine primarily so that I could help people bridge that gap between where they were and the best way forward for their health. And what I found when I became, as an attending, in the Navy, I didn't have the time to make that connection with my patients. And without that time to really build that relationship, it felt like the paternalistic, like, okay, here's your number, here's your pill, see you in 3 months. Oh, it's actually going to be 6 months because you can't get in. And you couldn't build that continuity. You couldn't build that rich relationship. And, direct primary care in the 6 months or the 9 months that I've been practicing it now, it has been so fulfilling to build those relationships, build that rapport, and really help people find a way forward that lines up with their values, that lines up with their goals. And it's not just like I'm dictating and telling them what to do. It's really we're finding the right way forward together. And I find that so enriching, so fulfilling.
And, just calling out here also that you were a high school teacher before you went to medical school. And I think that I taught summer camp for 8 years, and it was nothing like being a high school teacher at all, being a regular teacher during the school year. But I can just imagine, your desire to be someone that your mom should have had also was rooted in the relationships that you found with your students and the growth that you saw in the school years that you were with them. Because I remember with great fondness some of my high school teachers who I wouldn't be here today without the lessons that they taught me.
Yeah, no, I find that really enriching. And I worked as a high school teacher in between undergrad and medical school. I also worked as a tutor during undergrad as a way to make a little extra money. And in the Navy, the primary care, where a lot of our role is to train corpsmen who are kind of like the Navy's version of a medic, to train them from basically from corps school to being able to go out on a ship or to go out with Marines, and basically they're the doc. And that I find that also, I keep using the word enriching, but it adds a lot of value to life to be able to help people along, to deposit into people's lives and to invest in them. I've had so many people that I can look to that invested in me to be able to do that forward as well is really, yeah, it's an important part of my life.
I love it. Now, going back into your DPC now, the change that you've been able to see just in the time that you've been open in Florida, I want to jump
Hmm.
back to that this is not your first merry-go-round when it comes to DPC. And so I love, and I think it's so unique that you have gone to the DPC board, like, I am going to plan, I'm going to open multiple times. So can you bring us back to when you were in Tennessee and you were planning on opening a virtual option for DPC as your first attempt at I'm going to do this because I love this model in essence more than any fee for service model.
Yeah, yeah, absolutely. Well, my last duty station, it was just going to be for 1 year, was at Millington, Tennessee, which is kind of like the HR headquarters for the Navy. And the work there wasn't very fulfilling, but it was great hours. It was like, 8 to 3 every day, and with a mandatory hour-long lunch break for working out. So it was really a great time that I could invest in building a business model, picking out a name and a logo, and creating the business entity. And I knew that since I was going to be getting out, I wanted to start building up that patient panel before I got out of the Navy. And so I got, about 6 months before I started, creating the entities, started networking, getting out there, BNI, Chamber of Commerce, and it was starting to resonate with people. I had a couple of people who were really looking forward to signing up. And actually, one day before I was going live, there was a more, Memphis has a lot of issues with crime, and the family and I came to a decision that couldn't be the right place for us. And so we decided to pull the plug on that. And my wife, like I said, a civilian physician, she started looking all over the country for jobs and spent the next 6 to 9 months traveling from California to the Carolinas to all over. And yeah, so trying to find a great place, and found what looked like a good job in northern Colorado. And we found a great community there in Fort Collins, which is a fantastic part of the world. I left a little bit of my heart there, and we moved there. And about a year ago, we moved to Colorado and opened up on November 1st. And the clinic grew fast enough that it was actually paying for itself by the end of February. And unfortunately, things didn't go very well for my wife's job. And, cold weather was a little bit much for her. And my father's health was starting to fail as well. And he was in and out of the hospital a few times. And I was, born and raised here on the Gulf Coast, or in the Southeast rather. And my wife was born and raised in Mobile, and a job opened up in Pensacola, Florida for my wife. So we decided that for the family, it was the right decision. And it's a little bit painful, But up until a couple of days ago, I could say that we had lived in 3 houses in the last year. But I think it's absolutely the right decision coming back home, both for the family and to bring direct primary care as a physician to the Pensacola area. I'm slowly building a network here of good like-minded physicians as well. And recently ran into a friend or made a friend at my son's bus stop. And she was 1 week away from signing up with one of the corporate entities in the area. And I said, well, let me tell you about direct primary care. And she was off to the races. She has absolutely into it, read several books within a couple weeks, and now has her clinic. She's going to be opening up in November 1st. This message, it resonates so well with people who are just so tired of HCA people telling us how to do our job.
Absolutely. And, I just want to point out here, just zooming out on your journey thus far that you've shared, this really speaks to, what Dr. Phil Eskew mentioned in his podcast, that DPC can happen anywhere because, you were about to open a virtual DPC and people are interested. You open in Fort Collins where Dr. Kyle Hampton is over there in Arctos Direct
Mm-hmm.
Care, and people are joining your practice. And then you open again in Pensacola and people are joining your practice. And, I was so excited that you opened in June of this year. And by the beginning of September, you had already passed 30 patients. And now, like within less than a month, you're up to 50. And so it's like,
Mm-hmm.
it's insane that people truly are wanting DPC and whatever neighborhood you're in, rural, urban, doesn't matter. But this is how it's a very concentrated example of how true that statement is that Dr. Eskew made, that DPC can happen anywhere. I want to ask here though, because I was reading just your history and how you have gone to the mattresses and then you had to move multiple times. You continue to choose DPC and inspire someone else to open this November, which is amazing. So I want to ask you about when you've been in this place of researching different geographic areas, researching the economy in the different areas, and opening, onboarding patients, just being in that space multiple times, can you speak to us about how you've gone into this experience more prepared than ever before because you've had those experiences in Tennessee and in Colorado?
Yeah, I tried a few different things. I tried some Facebook advertising. I tried Google ads. I tried a magazine, getting some print advertising out there. The most valuable to me has been face-to-face conversations. Fort Collins has a fantastic Chamber of Commerce with 2 to 3 networking events every week, which is quite a bit for such a small community, but it really gave me a lot of great times to practice my elevator pitch, to let people see the genuine nature of this business model. And I think it's hard for that to come across in an ad, whether Facebook or otherwise, that like, oh, people hear like membership based, they think concierge, they think it's going to cost an arm and a leg, they think more greed, basically. But when you get that opportunity to talk face to face and people can see that your hunger to really help people, I think that comes across so much more potently. And so it's definitely, yeah, I think the face to face has really been the most important way to grow.
And let me ask you here, because your website, when I have a guest on, I'm looking at their website, and your blog on your Waypoint DPC website goes back to 2022. Did you maintain the name and then just open business licenses in different states with the name just continuing like LLC or PC or whatever it is based on what state you were in?
Yeah, so I've had 3 LLCs in the last year and a month. So fortunately, Waypoint DPC is there's not a lot of people on top of that. So the name was available in all 3 states. And fortunately, I was able to keep the same website and just change the address on there a little bit. I've become really good at applying for EINs. So yeah, yeah, it's a weird skill. Hopefully, I forget how to do it soon.
Well, I just love that it's so ironic that your name is Waypoint and literally it's just stuck with you and you've stuck with it the entire time. So I think it's very cool and it's very fitting.
Thanks.
When yeah, when you think about the challenges that you faced when opening. I mean, yes, it's a challenge of like, hey, this is what DPC is. This is a really awesome form of medicine. I get that the elevator pitch is one thing, but because you've been planning to open in different geographic areas, did you find the challenges were similar apart from talking with patients and helping them understand what DPC is? But in terms of the business challenges, did you find any differences in the 3 different states, or were they pretty similar?
I would say Tennessee, it was a little bit more of a foreign idea. There weren't a lot of DPC practices in Memphis at the time. The closest one was one in Olive Branch, Mississippi. about an hour away. And so it was an entirely foreign subject for them. And so it took a little bit more effort, and maybe it would have taken some more time to get off the ground there. Fort Collins, I was really fortunate. There were people like Dr. Hampton and I'll say Dr. Lenz and Dr. Magruder with direct family care of Northern Colorado is another great practice up there. And I worked very closely with both Arctos and direct family care of Northern Colorado. So people were very familiar with the idea in Fort Collins. I think that really helped. And there's a few practices here in Pensacola. Until recently, there weren't a lot of physicians doing it. The more PA and nurse practitioner driven. Nurse practitioners can practice independently in Florida. And so in the last 6 months, I think 4 physicians have opened up in the Pensacola area. So yeah, I think I'm really benefiting from a lot of the work, the hard work that some of the pioneers have done with DPC over the last decade or so.
Incredible. And for those people who are in their opening days, do you have any, like, you must do these things according to Dr. Calisch, in terms of pro tips that you have in the bag now because you've had practice at this a couple times?
Well, I mean, I think having a good research done beforehand is really important. Read the books, build your game plan. I think Douglas Farago talks about having a good long runway so that you can take off and have enough capital to make it through that. The biggest thing, though, is just to be genuine in your face-to-face networking events, getting yourself out there. And that's the message carries itself. It almost sells itself. Once people see through the how foreign it can feel to work without insurance, I think that's a big barrier for people. They want to have that security blanket a lot of times. But when you show them that you can provide a much more relational, nurturing product without the corporate entities, I think that really carries the day. So be confident in what you're selling. You're not just selling yourself, you're selling this fantastic model, and you're selling the old-fashioned relationship that we all kind of grew up watching in our movies and TV about the old-time family doctor that everyone was familiar with.
Absolutely. And now you mentioned that when you were looking to civilian life, your kids were about middle school age. So with them being middle school or high school, possibly even now, how has your schedule been able to adapt to meet those goals where you're not doing 50-50-50 in all of your roles, but more towards 100% because you have the autonomy that you have now?
Yeah, I have a great balance going on with my wife, and she's always home when the kids get home, and I'm always there to take the kids to school. So they get a fresh breakfast every morning, and I get to drive them to school and do the best I can to set them up for a good day. And that is just so valuable to me, and something that was so lacking in my time in the Navy, where the days were early and long, and oftentimes I wouldn't see the kids except to tuck them in bed. And now I can be there for the parent-teacher conference and be, there at the open houses and make sure that I'm there every day in the morning. So that's such a, I don't know, it, I'm really, yeah, it's one of the best parts of this whole thing is just to be able to make my own schedule and to create my own balance.
And in talking with them, have they made comments about, like, yes, your family has a significant history with the Navy, but have they made comments about entrepreneurship or, wow, like I really see how being your own boss allows you to be more autonomous? Anything like that that they've made comments on?
They definitely see that I'm happier now, and they don't just see it as a drag that dad has to go to work. They see that it's important. I think they're still kind of figuring things out with the new location.
Absolutely. And they're still young. And I think about how my eyes were on the world in my 20s, 30s, and now 40s. And it's like, wow, I really value the wisdom that comes with, each and every decade. So I think it's great though that they will be able to look back and see your guys' history as a family and where you've been professionally and where you are now. So let me ask you here, because you are with 50 patients and just growing, growing, growing. When you think about the future of your DPC, what are you doing now in terms of, documenting your workflows or reevaluating how a patient is onboarded? What are you doing now that you find valuable to help you keep things smooth, as smooth as possible, going into the future as you grow?
Yeah, I mean, looking at the future and seeing what the next 50 patients looks like as far as workflows, will definitely put me into the territory where I'd consider hiring a medical assistant or a nurse. And so I'm starting to codify some of these workflows a little bit. I'm taking a good hard look at my EMR right now, and I'm considering switching to another one because of some customer service issues. But I think that's an important thing to always have, like a process improvement mentality, to see how that goes. But I don't have any specific words of wisdom at this point. I'm still trying to figure that out as I'm growing.
But I think that's even just saying that though leaves the door open versus like, nope, have to do it this way because 16 committees have only approved this way to do things. Like
Yeah.
it's a very different world. And it brings, I guess, a lot less stress over if I wanted to change something, will I be heard? Heck yeah, you will, because it's your business. So it's
Right.
amazing. And I will put out a huge kudos to you in your enrollment page. I just love, like, this is something that I'm working on right now to improve upon. But I think you've done a beautiful job in terms of like, this is a streamlined page in terms of when you enroll, these are the things you need to do. These are the buttons you need to click on. And, kudos to you for that. But I think that, just being in this mentality of this is your business, it's your baby. In a lot of people's cases that they're, how do we cherish these businesses? We do things like constantly improve on our workflows and whatever we can do to keep the business, to keep us proud of what we're doing and also to keep it a really great experience for our patients.
Yeah. One of my last thing I ever do with an onboarding with every single patient, I set them down and I say, my expectation here is that I'm going to deliver something that exceeds your expectations. I want you to feel like you're coming to talk to your friend about your health. And I want you to always feel like you're heard and respected. And I'll just leave an open invitation that if I ever fall flat on that promise, I want you to let me know about it so that I can do a better job. I think that's really important that people hear that, and that they want you want to hear if there's a friction point or something that doesn't feel right, because everyone has a slightly different perspective on things. And I want to be open to that.
And I see it, as I'm sure everybody who's already doing DPC sees, it's this idea of like we're having a long-term conversation with our patients. It's not like, hey, I'll see you for your physical next year. Some people don't come in and they only want that, but it's like the ability
Yeah.
to have that long conversation is game changing. And
Yeah.
the ability to, like, I just love that our patients understand, like, you might not get everything right the first time, or you might try something in your differential and it doesn't actually turn out to be the case, but like you have the ability to pivot more quickly than you would in fee for service if something medicine is not benefiting the patient, or if they're having a reaction to it or whatever it is. And I think that that's something that I love seeing, the eureka moments in people's responses on the portal or their faces, that like, oh, this, I get it now, this is what DPC is. Yeah.
Yeah. Yeah. It's always really neat to see that.
One last question here. When you spoke to the doctor who was going to go corporate and now is going to be opening in November, I get that, like, in general, doctor to doctor, you can understand the frustrations, but like, what do you find is the most meaningful thing that you want people to hear when they're conversing with you about DPC?
I think that it's autonomy and agency for the doctor and the patient. Those, you can't have those without that good relationship. You can't have that without the ownership. And, there's some corporate entities that have tried to copy and paste the DPC model. And I think that loses a big chunk of the magic when the owner isn't the person there making the eye contact, sitting there with the patient. Yeah. I don't know if that answers the question well or not.
It definitely calls out the value of keeping healthcare local. And that is
Hmm.
that is something that, we, again, like going back to the pandemic, we saw the needs of a community depending on the needs of that community, and not in the state of California, the general needs are, forget that. It's like, who has access to, PPE, who has access to a primary care doctor, who has access to an emergency room. So it's quite incredible when you think about rebuilding healthcare from the grounds up, from the way that the foundations that we had healthcare for how many generations, where it was like, you are a person who has your doctor. Like, that should not be a thing that keeps people from going to the doctor. And yet it is, because of our culture is mostly fee for service. Like, people in fee for service are very familiar with what you experience in the Navy, lack of continuity. And nobody
Hmm.
We don't deserve that as doctors. Our patients totally do not deserve that. So this has been fantastic. And I'm so excited for the future that you bring to Pensacola, not only in your practice and your patients, but also because you are a fierce advocate for the movement. We will be talking more with Dr. Calisch about his take on the veteran exam as a veteran himself, and we'll be discussing his thoughts on how one approaches DPC as a future plan if they're still serving. So join us over in our Patreon community to hear that conversation, and check out the blog accompanying his podcast at mydpcstory.com. Thank you so much, Dr. Calisch, for joining us today.
Thank you for having me. It was a pleasure.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Marielle Concepcion.